So here you are watching drug-induced sleep endoscopy with BIS monitoring in a 57-year-old female with history of snoring and choking. Her body mass index is 25 and her apnea-hypopnea index is 87. So very, very high, very, very severe sleep apnea. She has a mild deviated septum anteriorly on the left side and a spur on the right. Turbinate hypertrophy is there. I'm going in from the left side. Out of 87, majority are apneas. 72 is the apnea index. So we expect something in the pharynx. Now she has no adenoids, as you can see. The salpingopharyngeal folds are also grade 0 by Agrawal's classification. And as we go inside, we can see a nearly complete collapse of the soft palate antero-posteriorly at this point of time. Her BIS is around 78, so in the perfect range. Now she has opened up. We can see lymphoid hypertrophy of the base tongue, which is also pressing onto the epiglottis. And you can see that it almost the palate collapse is almost complete. So high AHI, normal BMI, and you can see majorly AP collapse of the soft palate, partly lateral, but at this point of time we can see nearly complete collapse of the tongue base also. Tongue base is going and touching the posterior pharyngeal wall, pushing the epiglottis. So there is no primary epiglottic collapse, it's the secondary epiglottic collapse because of the base tongue. I'll concentrate here for a moment. And the base tongue is not only lymphoid hypertrophy. So as I can see here, lymphoid hypertrophy is a part of it, but overall the size of the base tongue is bigger. And you can see here the complete collapse of the base tongue, pressing the epiglottis. So it's a secondary epiglottic collapse, both muscular and lymphoid base tongue, right? And a complete collapse of the soft palate. The soft palate was clinically also and radiologically also little longer soft palate. But her now what I'll do is she's still sleeping with the mouth. She has a little retrognathia as well. Now I'm going to close his mouth completely and see what happens. Just by closing the mouth, the collapse is not improving. If I lift the mandible a little up now, I'm trying to simulate the mandibular advancement device. Lift it a little up. Definitely the collapse improves. So MMA is for sure going to work. Even a mandibular advancement device, if she can tolerate, is going to improve her airway to some extent. The palate will still keep on collapsing. Now, see, this is the simulation of the MAD. Even if we give the MAD, the palate will still collapse, right? Can you see that? Now there's no tongue base collapse, but the palate is still collapsing, right? So she will definitely require a suspension bridge pharyngoplasty along with a MAD. We can reduce the lymphoid component because her BMI is not high. We can do a tongue base reduction and palatoplasty, suspension bridge pharyngoplasty, but she'll still require a MAD. So she'll improve to some extent by the surgery, but she'll still require a mandibular advancement device because only by the MAD you can see palate will still keep on collapsing. All right. Now relax it. Now I'm leaving. So once you do not use the MAD, then the palatal collapse is also more intense, more complete for a longer period of time. As you can see here, right? So that's the complete assessment of, and you see the length. The length of the soft palate is quite a bit. All right. So she requires suspension bridge pharyngoplasty, uh, SOS, little coagulation of the lymphoid tissue on the tongue base, followed by MAD, and we might perform septoplasty. Can you see the elevated septum on the right? To the left side, turbinate hypertrophy, little deviation on the left in the upper part, anterior part, and turbinate hypertrophy as well as a spur on the right side. The deviation here is pretty prominent on the right. So we can perform all these surgeries in one step because her BMI is not high. We can just do a little bit of coagulation of the tongue base with a plasma wand. And so multi-level surgery, nose, palate, and a little bit of tongue base followed by MAD. Thank you for watching.